All right. Time is 5:05. I'll go ahead and get started. Good evening, everybody. My name is Kate Gross. I'm the nurse supervisor here at Hamilton County Public Health in Hamilton County, Cincinnati, Ohio. If you don't know, recently we started doing some TB summits for Hamilton County. This would be our third, I believe. We were going to do it in February, but it got a little bit backed up. March is actually World TB Month, I would say. Monday was World TB Day. So happy World TB Day to you all. To celebrate that, we're going to go ahead and get started with our TB Summit today. So I'm mindful of your time. Thank you for joining us. Let me move over to my agenda. So I'll just do probably not 15 minutes worth of introductions, but kind of a fast talker. But at least able to discuss with you who our presenters are today. Today we have Alex Waronko. He is our senior epidemiologist over infectious disease for Hamilton County Public Health. He supervises a team of disease specialists and epidemiologists who conduct investigations into communicable diseases, educate the public to control the spread of disease, and monitor health data for emerging trends in HIV, STIs, and infectious diseases. Alex and his team work to implement innovative approaches to disease investigation and provide actionable data and analyses that serve to protect everyone in Hamilton County from the threat of infectious diseases. In just a moment, I will stop sharing my screen and switch it to Alex. I also wanted to go ahead and introduce our second speaker in case I don't get to it afterwards. Dr. Moises Waman, he is our medical director here at Hamilton County, a trained physician in infectious diseases, immunology, and clinical epidemiology. He's an associate professor of medicine at the University of Cincinnati and serves as our medical director here at Hamilton County. He has experience training patients with latent and active tuberculosis. He serves as regional TB consultant for the Rutgers Global TB Institute. And as a researcher, Dr. Waman has experience conducting tuberculosis studies locally and internationally. So I'd like to welcome our speakers. Alex, I'll go ahead and have you unmute and I can stop sharing my screen. Prior to that, though, I just wanted to let you all know that this educational summit is allowing for continuing education credits. So at the very end, I will go ahead and redisplay this screen so that you are able to scan the QR code here. And I will also share our summit evaluation. So Alex, I will go ahead and mute myself and stop sharing so you can do the next part.
Fantastic. Thank you very much, Kate. Let me go ahead and share my screen and make sure I am sharing the correct screen. All right. Just want to make sure if I can potentially get a thumbs up that people can see my screen. Okay, awesome.
Yep,
Thank you very much.
I won't leave you hanging.
All right, everyone. As Kate said, my name is Alex Warnko. I'm the senior epidemiologist over infectious disease for Hamilton County Public Health, and I work within the Division of Epidemiology and Assessment. So today I'm going to be presenting on a case study in tuberculosis contact tracing, focusing on some practical applications of contact investigation principles that you might want to consider when you're conducting a work or school contact investigation. All right. So just today, we're going to be covering an overview of data in active tuberculosis in Hamilton County, looking at how to begin a contact investigation, working through a contact tracing case study, and then finally examining how to complete a contact investigation. By the end of my presentation, I hope that you'll be able to understand the temporal and demographic trends in tuberculosis in Hamilton County through 2024, learn how to start a contact investigation and identify susceptible contacts, examine how these contact tracing principles can be employed using a case study, and then identify the steps that need to be taken to communicate with contacts, and finally close out an investigation. So moving into the first portion of my presentation, I'm going to start with a review of data on active TB cases in Hamilton County between 2018 and 2024. This is going to help set the stage with some context for the contact investigations that we conduct into these cases. So starting with the disclaimer, these data were obtained from the Ohio Disease Reporting System, and they represent only confirmed cases of active TB in Hamilton County Public Health jurisdiction. So this does not include data on suspected TB patients that may have received empiric treatment, but were later determined to not be infected with TB. All of these data visualizations were developed by Hunter Johnson, a CSTE fellow stationed at Hamilton County Public Health using Tableau. So between 2018 and 2024, Hamilton County saw 129 active TB cases, with a peak in 2019 with 23 cases. And then you can see a, pardon me, to minimize my screen here. There we go. And you can see a peak in 2019 with 23 cases, and then a pretty substantial dip in identification with only 9 cases in 2020. This coincides with the start of the COVID-19 pandemic, where we saw similar reductions in reporting for not just TB, but for all non-COVID reported conditions. Most recently, in 2023 and 2024, they've shown very similar year-end TB burden, with 22 cases in 2023 and then 21 in 2024. We really saw a 4.5% decrease in TB cases between these years, but when we're looking at the raw numbers, it's practically the same amount. The visualization that you see on the bottom shows these TB case counts by quarter in the orange, and the black line is the associated moving average of cases for that quarter, looking back at the past 3 years worth of data. So in general, TB cases follow the average that you would expect, with some allowance for spikes that typically occur in Q3 and Q4 of a given year. You can see this occur in 2018, 19, most notably not 2020, but then for all the remaining years afterwards. These data help us to contextualize how the most recent full quarter of active TB cases stacks up against past quarters and helps us to see whether we're at, below, or above the average that we would expect. So moving on to some inter-Ohio comparisons. In Ohio, Cuyahoga, Franklin, and Hamilton counties represent the areas of greatest concern for TB, given their population density and the fact that they're primarily urban environments. Ohio Department of Health tracks the incidence of active TB cases for each of these counties on a yearly basis for surveillance purposes, and that allows us to compare ourselves with our most similar neighbors in Ohio. Since 2018, Franklin County, which is shown in the red line here, in the red line here, has shown the highest incidence rate for TB. 2024 most recently showed the highest incidence for all counties in Ohio over this entire time frame at 6.20. Hamilton and Cuyahoga counties, colored in the yellow, orange, and green, they have consistently displayed lower incidence rates than Franklin County and tend to closely mirror each other. Occasionally, you'll see them swap places, such as from 2021 to 2022, but for the most part, we align pretty closely with each other. Hamilton County, as of 2024, shows the second highest TB incidence rate at Ohio, with 2.54 per 100,000 population. All 3 of these counties, however, consistently meet or exceed Ohio's statewide TB incidence rate, which is the bottom line shown in blue. In 2024 as well, Hamilton County is off target for 3 of the primary CDC objectives for reducing annual TB incidence. These are the yearly incidence rate, the US-born rate, and the non-US-born rate. So in 2024, the incidence rate for active TB in Hamilton County was 2.54 per 100,000, which is nearly double the target rate of 1.3. This is being driven by TB in both US-born and non-US-born individuals, with rates of 1.03 and 25.21 respectively. And both of these have rates many times larger than the proposed objectives. This is just to set the stage for future improvement. Looking at where specifically TB cases occur in Hamilton County, we are able to map where TB cases live to varying degrees of specificity. But at least for the purposes of public display of data, zip code tends to be the most familiar and anonymous way of doing so. In the map on the left, you can see 3 zip codes that have been colored in brown that have borne the brunt of TB burden between 2018 and 2024. Zip code 45220, which is dead center in the middle there with 14 cases. zip code 45240 to the north with 13, and zip code 45238 to the southwest with 12 cases, cumulatively represents the home of 30% of all TB cases within the full time frame. The remaining zip codes were home to varying numbers of TB cases during the time frame, ranging from 1 to 8 cases per zip code. Looking at the data that we have on the right is showing aggregate counts of TB cases by race, sex, country of origin, and age category. And you can see that over the entire time frame, most TB cases have fallen into the following demographic categories: Black or Asian race, male sex, international country of origin, and falling within the 25 to 44 year age range. Age range is being chosen based on the U.S. Census Bureau's designated age ranges so that we can align our population counts to development rates. In addition to examining demographics in aggregate over this time span, we also want to take a look at demographic trends over time for each year to try and determine any year-over-year changes and determine whether there's been any shifts in demographics that we should be wary of and keep in mind in our response. This way, we can ensure that we keep on top of any needs to consider changes in communications, different avenues of contact, any resources that we may need to keep in mind, and various other factors. Looking at the data on the right for sex and country of origin, you can see that the distribution for TB cases between male and female sex and international and US-born origin has remained pretty stable between 2018 and 2024. When we look at race, however, on the left side of your screen, you can see that there's been a shift towards more Black or African American cases shown in the orange bars in 2023 and 2024. And during that same time frame, there's been a substantial reduction in the number of Asian cases, which are shown in the dark blue. So knowing that most TB cases are non-US born, racial demographics are very closely intertwined with international trends, such as increases or decreases in TB abroad or changes in immigration policy or trends. So something to keep in mind there. In nearly every year on record, more cases have fallen in the 25 to 44 age group, shown in light blue, than the other age groups. The one exception to this is 2023, where there were slightly more cases in the 15 to 24 age group. Again, that was a 1 year deviation, so it'll take more years worth of data to really see if that's the beginning of a new trend or if that was just a one-off deviation, but it's worth taking. There are also a number of risk factors that have been associated with acquiring active TB infection or making active infections more severe based on a variety of research studies over the years. These following factors are HIV positivity, institutionalization in a correctional facility, excess alcohol consumption, homelessness, and injection drug use. So between 2018 and 2024, 2.33% of TB cases were identified as HIV positive, 0.78 were institutionalized in a correctional facility, 6.98% reported excess alcohol consumption, 5.43% reported homelessness, and 1.55% reported injection drug use. Now, these are small percentages, and you can see that there's more cases that lack these risk factors than necessarily have these risk factors. That being said, it's still very important to continue to gather this data so that we can get a comprehensive sense of the non-infectious factors that need to be considered when we're investigating and treating TB cases. Now, the next section of my presentation is on beginning a contact investigation, which I have subtitled "In Pursuit of a Line List." I will note that covering all the ins, outs, and complexities of contact investigation for tuberculosis could easily take two full summits, and I only have about half of one summit. So I'm going to be prioritizing some specific elements of the process over others to really narrow in on the most important elements. But if you're interested in a full description of the process, you can review Ohio's tuberculosis program manual, which is available through the Ohio Department of Health. This section on beginning a contact investigation is going to be an abbreviated practical application of that TB program manual. I'm going to be emphasizing the factors that are most important for starting a contact investigation and for identifying high-risk contacts when work or school settings have to be investigated. Before we start going into more detail, I'll state that this is starting with the assumption that the initial index patient's closest circle of high-risk contacts, in most cases the family, has tested positive, which is going to necessitate expansion of the circle of risk into the next widest group of contacts. The TB program manual lists 9 total steps in the TB contact investigation process. We're going to be focusing on 5 of these steps today, which are 3, 4, 5, and 4 of these steps today, which are 3, 4, 5, and 6. Field investigation, risk assessment for TB transmission, the decisions about the priority of contacts, and the evaluation of contacts. We'll be extracting key points from these steps. The remaining steps, 1 and 2, and 7 through 9, they're useful for identifying contacts or locations of concern, as well as the clinical approach to cases and contacts that test positive. When you are beginning a contact investigation, there are 6 key factors to keep in mind as you investigate, which are shown here on your screen. These are proximity of contact, duration of contact, frequency of contact, factors specific to the index patient, environmental factors, and then sort of your X factor, any additional context that hasn't otherwise been considered in any of the other elements. So we think about the index patient, the contacts of the index patient, and their environments. Each of these is going to be described in more detail on the following slides here. First and foremost, we need to determine 1, how infectious the index patient's particular case of TB is, and 2, how likely they are to have spread this infection to others. This depends on the type of tuberculosis. Pulmonary, pleuropulmonary, and laryngeal TB are more likely to be transmitted than non-pulmonary or non-laryngeal TB, just due to the fact that more of the infectious particles are going to be expelled with each breath in these types of TB. Additionally, patients who have a positive AFB smear and sputum culture are going to be more infectious than patients that do not have positives. Looking at practically, if there's enough TB in your system to get a positive smear, there's enough to spread the infection to others. Tuberculosis featuring lung cavitation is also more infectious than tuberculosis without cavitation. And we also have to consider the age of the index patient. In general, I'll say general, children under the age of 10 rarely spread TB, unless they have severe pulmonary TB. So they're rarely going to spread TB to their contacts. And finally, TB patients who are undergoing treatment are far less contagious than patients who are untreated, and they also become less contagious over time as their treatment progresses. As they get closer and closer to clearing the infection, there's fewer germs to spread, and so likelihood of them spreading it to contacts just gradually drops over time. Understanding the index patient's individual case of TB helps to determine how many contacts have to be considered, as well as the time frame for the period of communicability. A chart from Ohio Department of Health is shown on the right here, showing the look-back periods, or the beginning of the likely period of infectiousness, under 4 different scenarios. And you can see that in most scenarios, we're going to be looking back about 3 months before symptom onset or the first positive finding for TB. The only exception to this is if a person is negative for symptoms, negative for the AFB, and negative for cavitation. If after all of this consideration there's still suspicion, then we're going to look back 4 weeks from the suspected diagnosis, because given all this, they haven't been infectious for as long as others who may be showing any of these other symptoms. Additionally, the characteristics of the index patient must be compared against the nature of their contact with others. This is going to be measured by 3 similar but distinct concepts, which are proximity, duration, and frequency. Proximity is a measure of how physically close a contact was to an index patient. So while TB is an airborne disease, the likelihood of transmission increases the closer a contact gets to the index patient. If you visualize your own breath as a cone that comes out of your mouth or your nose every single time you exhale, there's going to be a higher concentration of infectious particles near the base of that cone, nearer to your mouth and to your nose, than there is going to be at the top of the cone where it's started to spread out. So in practical terms, you can think of the proximity of a contact as being how close to the index patient's mouth and nose were they. Duration refers to how much time on average a contact spent around an index patient while they were contagious. So the longer a contact spends around an index patient, essentially the more opportunities they have to become infected. With each breath, and in general, a person is going to be taking in the same volume of air with each of their breaths, unless you're accounting for exercise or anything like that. And with each inhale, there's going to be a small chance for them to inhale an infectious particle. With more and more time, that's going to become more and more likely that there's going to be an infectious particle within that breath. Finally, frequency refers to the number of times that a particular type of contact occurs. So each time a contact occurs with an infectious TB index patient, there's a risk for infection depending on the proximity and duration of that contact. Over repeated contacts, I'm an epidemiologist, so I have to tie it back to probability. In the long term, even unlikely events become more probable, and the more you do something with an unlikely outcome, the more probable that outcome becomes. Let's take, for example, a medium distance, short duration contact, interacting with a cashier at the grocery store. That's not a problem if it happens once or twice. If, however, this medium distance, short duration contact happens on a daily basis over the course of a year, that sums up to a lot of time spent in contact with the infectious index patient. All these factors together are taken into consideration when we look with index patient factors to determine who needs to be included in a contact investigation. Now, finally, we have to consider environmental and contextual factors. This encompasses the physical, social, and what I'm terming logistical circumstances in which contact occurs with an index patient. Environmental factors are going to consider the physical makeup of the space or spaces in which contact occurred. Contact that occurs outside in the open air, that's of little concern for TB transmission, considering that you've got wide area for a person's breath to spread and air circulation just owing to natural airflow. In contrast, however, contact that happens inside is going to give a lot of space for an airborne pathogen to linger in the air. All other factors being equal, contact that occurs in a smaller space is a greater risk for transmission than contact that occurs in a larger space. In a smaller space, the number of infectious particles, let's say, going back to the cone example, assuming you breathe out the same amount of air with each breath, that the base of the cone is going to be a little bit closer to everyone around you in a smaller space. And everybody else is going to be breathing in the same volume. So in sum, in a small space, the smaller a space gets, each breath has a higher chance of having a TB germ. Taking a look at ventilation, it's kind of a double-edged sword, actually. Really good air circulation in a room is going to pull infectious particles out of that room and reduce the risk for people in that room if there was an index patient in there. However, without proper air treatment, such as direct airflow to the outdoors or things like HEPA or MERV filters, this can unfortunately also pull those particles into an entirely separate space, which can allow an index patient to infect people that they may never have met or even seen. Finally, we also have to consider other contextual factors, namely, what were people doing during the contact? Were they breathing heavy? Were they laughing pretty consistently or raising their voices? Were they singing? All these matter to determine who needs to be considered when we're looking at a contact investigation. Now, I want to present a case study of a contact investigation now, one which considers all of the prior patient, contact, environmental, and contextual factors to identify a specific set of contacts for follow-up and evaluation. Starting off by setting the scene with the patient is 11 years old and attending the 5th grade. Recently, the patient started developing cough, night sweats, hemoptysis, fever, fatigue, chest pain. I wrote down night sweats again because apparently it's that important, but they're displaying every possible classic symptom of TB all at once. But unfortunately, it takes some time for a clinician to recognize these for what they are, given how rare TB can be in pediatric patients. The symptoms started in late September, but it was 6 weeks from symptom onset to a positive test and diagnosis. They're diagnosed with active TB infection, but the patient is a child. Normally, children aren't going to be a worry for spreading TB, so contact investigation isn't generally going to be needed beyond the immediate family. So the health department is notified, family tests positive, all would be well, but I say well, they're still going to need to go through LTBI treatment and active TB treatment. But it turns out the patient was diagnosed with miliary TB. This is a severe form of TB infection that's disseminated through the bloodstream to multiple organs. And with the most recent numbers available, miliary TB makes up around 1 to 2% of all TB cases. And from the data before, people aged 0 to 14 made up 7% of all TB cases in Hamilton County from 2018 to 2024. Now you match those two unlikely circumstances together, and they combine to make one very rare event: a pediatric TB patient of low to average infectivity, which means now you have the honor of conducting a school-based contact investigation. For further setting of the scene, we want to then take a look at the school itself. This school has 700 plus students in grades K through 6 and 90 plus staff for a total of roughly 800 students and staff. It's in a large, urban, modernized building. The grades are split into cohorts that will regularly rearrange so that everybody in those 100 plus student grades is going to have a chance to intermingle and meet new people. Thankfully, within classrooms, they do have assigned seating, but there's also extracurricular options considered. Now, 800 students and staff is a very concerning number to hear when you're looking at a contact investigation into an airborne disease. Our first thought should be, let's think of ways to bring that number down and focus in on the people who are at highest risk. So to do that, we are going to consider all the factors that I discussed before. Looking at index patient factors, this patient is low to moderately infectious. So we're really only going to need to focus on contacts that were both frequent and long duration. That leaves us with the entirety of the fifth grade, as well as the people in classrooms around the fifth grade, because we have to consider, before moving on to other steps, we don't really consider the environmental factors, but those come in next. Thankfully, after talking to the school, you learn that there's modern HVAC systems in place with filtration, which means the chance of spread between classrooms is low, and we can really stick to just the fifth grade, which is about 100, comprises about 100 students. Like I mentioned, this school cohorts grade so that people can intermingle with different groups and learn and get to know different people. But that actually helps us because it restricts us to an even smaller subset of the fifth grade, plus the fifth grade teachers. That puts us at about 60 to 70 students and staff in total, and that is much more reasonable than 800. We have reduced this by a factor of more than 90%. And we can reduce this even further by considering only the proximal contacts. It's at this point that it's time to look at some seating charts and be very thankful for assigned seating. I'll note before we start, I drew all these seating charts myself, and I'm not a great artist, so please do not make fun of me or I will cry and this will be very awkward. Taking a look at English class to start, we're looking at, the good news is school thoroughly documents their seating assignments in every class, both the ones where the patient was present and where they weren't present. The bad news is that every single class documents a different arrangement in a different way, so we need to carefully review every single variation of a seating chart that we can possibly see. And this brings up a very key point about contact investigations. In a contact investigation, you really hope for the best, but you work with what you get. Things can be orderly sometimes. Things are rarely pretty and ordered in the way that we want them to be, and they always hold some surprises. So with that, let's jump right into it. The goal of seating charts is to find the people who sat closest to the case for the longest amount of time during school hours. Given all of those circumstances, these people are going to be at the greatest risk of contracting an infection. You kind of got a preview already, but in each seating chart, the letter I colored red or maybe orange on your screen, I don't know how it will show up, that represents the index patient. And the letter C's, who are colored green, are going to represent the contacts who consistently sat closest to that index patient. All of the other C's in white are lower risk contacts, I should say. So, focusing in on English class in the first and second quarter for cohort 1, You can see in quarter one, the index patient sat in the top right of the classroom, closest to the smartboard. I don't know if they still call them that. That's what they were when I was in school, so I'm sticking with the language. But you can see here colored in orange, and they have 1, 2, 3, 4, 5, 6, 7 contacts around them in this particular arrangement of seats. For this, we're really focusing on the contacts that are in the immediate circle, because the ones in front are obviously going to be getting the patient's breath as they just look at the board, breathe, take notes, etc. But we also don't know to what degree they might be turning to talk to the people around them or behind them, and the desks are packed pretty close together, so just to be safe, we include them as well. Taking those same principles into account in the second quarter, we identify in this case that the index patient was seated in further to the back and the left of the classroom, and because of the way it's arranged, they actually only have 5 contacts around. I can't count, they only have 6 contacts around them. My apologies. So 7 from the first, 6 from the second quarter. Looking at gym class, what is this arrangement? Is the top of the paper a wall? Is it a stage? Who really knows? Unfortunately, you work with what you get. And we know that the index patient was either sitting right up against a wall or at the very front of the class with only 5 other close contacts around them. Looking at math class, we now have a different seating arrangement. Instead of the typical like scatter plot seating arrangement, we now have a series of desks that are arranged in pairs, which actually helps us because this means that we only really need to worry about the one student that the index patient was sitting directly across from at any given time, because these desks are also spaced farther apart from each other than in the other classroom. So in quarter one, we have 1 contact, and then when they move to a different seat in quarter 2, we have another contact to add. Finally, we're going to take a look at, or not finally, I'm sorry, we're going to take a look at music class. This has your standard bleachers set up with 3 bleachers, people able to choose from a variety of instruments, they sing. So when we're looking at this, we're considering that the bleachers are spaced pretty decently far apart, at least farther than the desks in the first classroom would have been. So our main concern is going to be for the 3 people in the cone in front of the index patient and the 2 people to either side for a total of 5. We've only got 2 more different variations of seating charts because that was the limit of my creativity. But taking a look at social studies, we've now got a tiered arrangement, I guess you could call it, where it's a whole bunch of horizontal tables with multiple people sitting at them, all facing the teacher's desk to take notes. In the first quarter, the index patient was sitting right at the very front in the seat closest to the door. So we really only have to worry about the 2 contacts right next to the patient. They're spaced far enough apart that the ones on the end of the table aren't going to be at high risk, and neither are the people behind the patient. However, as we move into the other quarter here, you can see that the index patient is now sitting central to a table further back. This means that we kind of take that 2 down principle and expand it out on both sides. So in total, we're going to get 4 from one quarter, 2 from another, or a total of 6. Now, finally, we are almost done. Looking at science class, this has an arrangement where it's a whole bunch of bundles of 5 desks at once. Again, kind of similar to the previous class where it was pairs of desks. This actually helps us because we really only have to worry about the people in that cluster of desks. This time, it's just more. So in second quarter, you're going to have, in first quarter, you're going to have 1 set of 4 contacts. And in second quarter, you're going to have another set of 4 contacts. With that, we are done. But I have to be dramatic. We're almost done. There are some contextual factors that we have to consider before we call this a day. 2 of the seating charts were unique from the others, and some of you may have caught this in the previous slides and been thinking, wait, he's providing misinformation here. Why is he doing that? It was for dramatic effect, I assure you. 1 of these seating charts represents gym class. It was this one that you can see here, where they were either up at front or back against the wall. Gym class involves a lot of movement, heavy breathing, intermingling, and that increases the transmission potential for TB because you're going to have more air being expelled with each heavy breath, and you're going to have more breaths being taken as people try to catch their breath. Each big breath out is a chance for TB to be spread, so everyone in the gym class needs to be considered high risk. Additionally, all the other contacts are also going to be breathing heavily and taking in a larger amount of air. So essentially, the index patient is putting out more infectious particles, and everybody around them is taking in more. This seating chart here represents music class in the classic bleacher setup. Now, for much the same reason as gym class was a concern, music class is also a concern because in this particular music class, as you learned from the school, singing is a frequent activity. Singing is going to put everyone in the room at high risk for exactly the same reasons as gym class. Maybe not as high a frequency of breaths, but let's say you're trying to hold a high note for a long time. Maybe the index patient is one of those people who's always like continuously got that low bass rumble in the back of the choir. They're going to be putting out a pretty consistent amount of air. Additionally, you want to consider the fact that in each class, teachers aren't going to stay at the same spot the whole class. They're not always going to be at the desk. They're not always going to be at the board. They're mobile. They might have activities they're going to conduct, or they're going to walk among students. Generally, they're going to spend some time close to all students, and there's no easy way to tell how often and for how long they were in any particular contact with the index patient. So they need to be considered to be high risk as well. And then finally, you also want to consider contacts in extracurriculars. Make sure to double check whether the contact has been participating in any non-classroom activities within the school. You'll want to consider sports here. Outdoor sports present a lower risk than indoor sports for the same reason that we talked about with regards to the room size and airflow. And activities that involve a lot of talking also present a higher risk than silent activities. The index patient here belongs to a speech club that sat in a small group format. So all of those contacts have to be added to the list, and they may encompass people from other grades as well. Now, once you've got all of those contacts in place, considering all the contextual factors, you've put the principles of contact investigation into action. We know who the high-risk contacts are after having gone through the seating charts. Now, what do you do with this information, and how do we follow through with the contact investigation? First and foremost is going to be the almighty line list. You want to first create a detailed line list that will allow you to identify high-risk contacts. I highly recommend developing a template spreadsheet that is going to ask, at a minimum, identifying information for contacts, have multiple elements of contact information for them, their residence address, and if you are doing an investigation into a school or any other area where you expect that there's going to be contacts under the age of 18, you also want to ask about guardian information and contact information. It's also important to ask for language. We can't assume that everybody is going to speak English. So if there is information on what preferred language contact has before you reach out to them, the better. That way you can get an interpreter ready and be ready to ask questions in the language that they prefer. You can see here that there is an example in the first spreadsheet line of the aptly named test example son, who has the email address obviousalias@notarealemail.edu. There's lots of different ways to collect this information for identified contacts. If you have an existing external source, such as maybe a school nurse or something if you have an existing external source, such as a line list that has already been sent to you, you can do this yourself. Take what they've given you, put it into your own template, and you're going to be good to go, barring requests for any missing information. Otherwise, if the contact occurred in a facility such as a healthcare provider, a school, or a workplace, you can have a representative from that agency provide the information. There's no one-size-fits-all solution since each investigation is different, but just try to find the person who's going to have the most health information about the people that you want to take a look at. Finally, you want to have some space to record information that's relevant to the health department. So since each investigation is different, you want to consider other information to collect. If their contacts are from a school, are they students or are they staff? If the contacts are at a workplace, what department do they work in? What shift do they work? All these can help down the line when you're trying to determine determine the importance of findings or determine who may need to be tested in a specific manner. Finally, once you have all the basic information for contacts documented, also add space for your own health department data collection to the line list. At a minimum, you want to consider the following elements, which are going to be who's been assigned to follow up with this contact, tracking metrics for the contact attempts, any history of TB reported by the contact, their symptomology, their any progress in their labs, as well as space for notes that may not fit in any of the other buckets. So after getting all the basic information for all the contacts, you want to try to take some time to plan ahead if you can. Planning ahead is essential in investigations like this. Every one of these people is going to need to be tested or evaluated for TB in one way or another. So this needs to be documented in the medical record of some kind. I will note that this does assume that you have access to a medical record, such as in a clinic space. So this step may not necessarily apply if you are, say, going to be outsourcing I don't know if outsourcing is the right word, but if you're going to be sending people to a space that is not quite your own. So using the basic identifiers and demographics in the initial line list, you want to create a record in the medical record for each contact. Additionally, the medical record is going to serve as a pretty good space to document any contact attempts and the outcomes of conversations in addition to the line list. That way you have the same information in multiple spots. Redundancy is almost always going to be better. Now we also want to try making our first approach to these contacts. For this, you're going to need to create a notification letter, which is going to need to be drafted, reviewed, and approved. I will note that this element is included here for practical purposes, but in reality, the step of getting a notification letter written should be started much earlier in the process. Basically, as soon as you realize you're going to need to be doing a contact investigation, start developing a letter with at least the basics. These basics include naming the exposure location, as well as specifically identifying the recipient as a person who is exposed. You want to provide them information on TB and state exactly who should be tested. This is to try and cut down on any concerns by friends or family who are also going to have access to the letter. You're going to want to get ahead of them wanting to get tested by saying, oh, I was a contact of a contact. That means I'm at risk. They are not, at least not now. So we want to be very specific about who needs to get tested. You also want to recommend specific tests that should be done and note any cases where additional follow-up or alternate procedures may be needed outside of the norm. Most importantly, remember that getting this letter is going to be really scary and overwhelming for most people unless they have nerves of steel. You're going to want to give the recipients specific instructions and multiple options on how they can be tested, whether that be through the health department clinic, a private lab, a partnering provider, or contacts preferred providers. You want them to know exactly what they need to do and how it will be done so they feel empowered to go out and perform that exact function. Now, finally, we look at the actual contact attempts. So with a line list and medical records and a notification letter, now we initiate the last phase of contact investigation, which is actually calling and reaching out to and speaking with contacts. I say speaking, but our first contact attempt is a letter, so I guess it would be more of a written attempt. The letter is going to be your first contact attempt, so mail it out, give the post office some time to deliver it, give the recipients time to digest the information and start to reach out. When they do reach out, you want to make sure that you assess their current symptoms and any prior history of TB, LTBI, or treatment, and document that in the line list. These answers are going to determine what testing they need and where they get it. So make sure to document your findings in the line list and make a note in the medical record once you finish the call. For those who don't reach out to you after the first contact attempt, you now have to turn the tables and reach out to them. After about a week, accounting for the post office and reading and following up on the letter, you want to reach out to them now via phone. Make your first phone call and be prepared to explain who you are and why you're calling, and have a voicemail script prepared with a request to call you back if you don't manage to reach them at that time. Again, we wait about a week. Thankfully, TB is a very slow-growing disease, so it's not one that needs to be done with a huge sense of urgency. But after that one additional week, we make a third and final attempt for those who we couldn't reach in the second week. At this point, anybody who doesn't respond after this third attempt and voicemail is going to be considered lost to follow-up unless they call us back after an extended period of time, in which case, still document everything in the line list and the medical record. Just know that you may have to pull this information up at a moment's notice. And as one final note, plan your outreach accordingly and bring in help when you need it. If you're going to have to reach out to 40 contacts, don't do that on your own because that's going to be way too much. Recruit or volunteer for coworkers and start to share the load. Rather than distributing 40 to 1, do 40 to 5. 8 is much more manageable. That is quickly summarized the process of planning, starting, and completing a contact investigation. It is key to note that just like all cases are different, all contact investigations will be different as well. So always be careful to assess any contextual factors, since these can be what help you uncover more people at risk. For example, in the case study, noticing that 2 of those seating charts were for gym and music class, both of which are high-risk encounters, and we may have missed if we weren't really paying attention. If any positive tests occur within this batch of high-risk contacts, then we repeat the process one ring further out. Tying back to the school example, let's say that any of those who sit nearest to the patient test positive, then we need to move out to whole classrooms. If any of those test positive, move out to adjacent classrooms. If any of those test positive, you're back at the 800 number, unfortunately, but that's just the way things go sometimes. So, in summary, I hope that you understand the temporal and demographic trends in tuberculosis in Hamilton County through 2024, that you've learned how to start a contact investigation and identify susceptible contacts, that you examined how contact tracing principles can be employed using a school-based case study, and that you can identify the steps that you take to communicate with contacts and close an investigation. I want to take time to acknowledge all the people that I have written down here. There's a lot of names, so I'm not going to read them all out and hit my time limit. Hey, look at that. But I just want to note that every one of you on this list knows just how much time and effort goes into contact investigations. And so I appreciate all of you and all of your contributions to this presentation. I have some references here that you can also make use of. You'll note that the second one is the Ohio Department of Health's Ohio Tuberculosis Program Manual chapter on contact investigation. So that is a resource that you can make use of if you want to learn more about contact investigation. Otherwise, I truly hope this has been informative. I know there's going to be a Q&A session at the end here, but please feel free to reach out to me if you have any questions. Thank you, and I'm going to stop sharing my screen now and turn it back over to Kate.
Alex, thank you so much. That was an awesome presentation. It really did highlight exactly how we move through contact investigations with a great example of a school investigation. So thank you for sharing that. Up next, we have Dr. Moises Waman, who's going to give some updates on drug susceptible and drug resistant tuberculosis medication. And Dr. Waman, you can share your screen whenever you're ready.
Okay, perfect. Let me see. Can you hear me okay?
Yeah, you sound great.
Okay. I have too many screens here. Can you see my screen?
Yes, it's perfect.
Okay. Is it a full screen slide?
Yes.
Okay, perfect.
You did it.
Yes. Okay, first step check. Okay, so well, first of all, thank you, Alex, for that wonderful and very informative presentation. I will spend a few minutes on updates that were recently released on treatment of drug susceptible and drug resistant tuberculosis. I don't have many slides, so we will focus on just a couple of them, and then we can leave questions for the Q&A session. Okay, so let's see. As Kate highlighted, this summit kind of coincides with our World TB Week Day. The official day was March 24th, which was Monday. And for those of you who don't know why March 24th, it's because it celebrates the day when the announcement of the discovery of Mycobacterium tuberculosis as the causative agent of tuberculosis disease was announced by Dr. Robert Koch. So that's why, and that was back in 1882. So we go back a long time, but that's why on March 24th each year we celebrate World TB Day. Okay. And always remembering think, test, treat TB, you know very well about that. Alex did an excellent job showing you some of the trends in terms of tuberculosis diagnosis in Hamilton County and within Hamilton County. And now getting into an overall picture of what's going on in the United States. Some of you may have seen some news already, but this is provisional data that can be accessed through this through the CDC website that shows now already, including the 2024 year data, that for last year, there were 10,347 TB cases provisionally reported. This report is through early March 2025. So the official final report usually comes later in the year, but these are the numbers as of now, which will correspond to a rate of 3 TB cases per 100,000 population in 2024. And then this represents a percentage increase both in the case count as well as the rate in about 8% from 2023 to 2024. And if you look at the graph, so this is a little bit of a busy figure, but over here you have the number of cases. On the other side, you have the incidence rate, cases per 100,000 people. And then here in the, this will be the x-axis, you have the year, right? So it starts with 2010, and then we go all the way to 2024. And if you just focus on 2024, we unfortunately are back at numbers of cases that we were seeing in the early 2010s. So unfortunately, we have rates that are up back to where we were 10, 15 years ago. There was kind of a decline in 2020, which is more of an artificial decline given the probably sub-reporting that happened during the start of the COVID pandemic. But now we're back, unfortunately, at very high rates historically for the United States. And globally, TB again has taken over COVID. If you go 2-3 years ago, COVID was the #1 cause of death due to a single pathogen in the worldwide. But now tuberculosis again is the #1 cause of death due to a single infectious pathogen worldwide. Now, if you wanted to go into the details, you all know about these based on the epidemiology of tuberculosis in the US. The dark, if you go by year, the dark blue will be the fraction of cases that are coming from non-US born population, right? Which is usually 70% plus of the total number of cases. And that applies also to Hamilton County and other counties in the area. And the light blue will be rates or number of cases in US born. So Ohio as a state reported an increase in the number of TB cases from 190 in 2023 to 198 in 2024. And just for those of you who follow the yearly MMWR CDC journal reports, I think that the official provisional data with tuberculosis trends for 2024 should be coming out tomorrow. They usually publish the reports every Thursday, and I think they like to coincide with the week when World TB Day happens. So stay tuned. Take a look at MMWR tomorrow, and you'll probably see the official reporting on these numbers for 2024. So that just shows the overall increase in the United States. So this helps me to thank you all, because one way or the other, I know that we have a broad audience, but I know how hard you all work to try to decrease, to try to control and eventually eliminate tuberculosis from the US. And I know that some of you have work that goes beyond the US as well. So thank you all for the efforts. There is a lot of work to do in terms of tuberculosis prevention. And what Alex just highlighted is very important, because that is one of our most important tools to try to minimize transmission in our community, which is identifying contacts from cases that are diagnosed with active tuberculosis. So very important work related to contact investigations. Thankfully, because of all the good work that is done by our counties, transmission is not the major driver of new diagnosis of tuberculosis in the United States. Actually, the main driver of tuberculosis, active tuberculosis diagnosis, is reactivation of remote, what we call latent tuberculosis infection. So that's why also all the prevention work that you all are doing with trying to with doing a quantiferon PPD testing in populations where there is an indication to do testing and offering treatment for latent or what we now call TB infection is very important. Okay. So I was tasked with highlighting this document that you all can find in one of the major scientific journals from the endorsed by the American Thoracic Society, that provides updates on the treatment of both drug-susceptible and drug-resistant tuberculosis. And you will see here that this was published. The issue was actually the article was published in January 2025, so just a couple of months ago. But this was actually cleared and provisionally reported back in September 2024. So it has been out for a few months right now. And these updated recommendations are endorsed by several of our societies, both scientific societies as well as public health agencies, including the American Thoracic Society, the CDC, the ERS means the European Respiratory Society, and then IDSA, which is the Infectious Diseases Society of America. And these are basically clinical practice guidelines. And I'm very happy to, some of you may recognize this name over here, Dr. Wan. Is based at Columbus at Ohio State. So it's very good to see representation from Ohio in our national and international clinical practice guidelines. So and this is the main slide I wanted you to focus. It's a busy slide, but I wanted you to focus on this slide. What are the highlights of these updated recommendations? Again, they were published back in January 2025, so 2 months ago. But they are all going into regimens that thankfully are shorter. And we will start with the first recommendation. So among adults and adolescents with drug-susceptible pulmonary tuberculosis, active tuberculosis disease, they can be treated. So traditionally, we have treated these patients with 6 months of antibiotics, right? The classic RIPE regimen. But now there is an option that we could treat these individuals with drug-susceptible pulmonary TB with a 4-month regimen, antibiotic regimen instead of 6. So the panel recommended 2 months of, and these are the acronyms for each of the antibiotic names: isoniazid, rifampicin, which is different from rifampin, okay? Different from rifampin. This is a different rifamycin. It's in the same class, but it's different. Rifampicin, pyrazinamide, which you all know, and moxifloxacin, which is a fluoroquinolone that many of you are probably familiar with. So when you put this as an acronym, is HPZM. And then this is the first 2 months. And then the second 2 months, so the second part of the 4-month regimen, you can drop the pyrazinamide, and then you continue with isoniazid, rifampicin, and moxifloxacin. So that's why here bolded, you will see that the acronym of this regimen is 2-HPZM, which is 2 months of isoniazid, rifampicin, pyrazinamide, and moxifloxacin, followed by 2 months, 2-HPM, which is 2 months of isoniazid, rifampicin, and moxifloxacin. So that's great. So now we have a regimen that comes down to 4 months that we could potentially offer to our patients. There are some caveats with this regimen. In the Q&A sessions, some of the potential barriers for implementation may come up, but I will recommend you to, before considering this regimen, just making sure that either you as a provider or whomever will be providing the medications, that they will be able to provide enough supply for the 4 months. We have been dealing with rifampicin shortages off and on. The other consideration is that rifampicin is much more expensive than rifampin, so you have to make sure that, for example, if you are getting coverage through one of the local jurisdictions, that this is a regimen that your jurisdiction will be able to afford. And there are some other considerations as well, but we'll stop there. But it's great to see, and this is an example of what we're trying to do within the TB field, trying to come up with regimens that will be shorter, because we know that the shorter the regimen is, the more likely the patient is going to complete the regimen, right? Okay, so 4 months of this 2-HPZM, 2-HPM regimen. Now, the second recommendation is for kids, for children. So children with non-severe tuberculosis disease can be treated with 4 months of our traditional RIPE regimen instead of 6. So that's also an advantage, and this comes with from the SHINE trial. And by the way, you know, all these recommendations are based on very solid data that comes from clinical trials, multi-center trials that included not only U.S. sites but included international sites as well. This comes from the first recommendation comes from Study 31, A5349. Which was a large study, and this one is coming from the SHINE clinical trial. So most children with non-severe tuberculosis disease can be treated with 4 months. So the panel recommends 2 months of, this is a traditional regimen, right? Isoniazid, rifampicin, pyrazinamide, and ethambutol. So those first 2 months with the regular RIPE therapy, followed by 2 months of isoniazid and rifampicin. So that's your classic 2-HRZE, 2-HR, and this is indicated again for children and adolescents between the ages of 3 months and 16 years of age. And we can get into these on the details, but I'll refer you to the guidelines. The guidelines provide a very clear definition of what non-severe pulmonary TB disease is. For example, it's required to qualify for this shorter regimen. It's required that the smears at time of diagnosis are negative. So if there was collection either by gastric lavage or by gastric aspirate or by sputum collection or whichever other way that the smears are negative, If there is lymphadenopathy, usually cervical lymphadenopathy is fine. If there is mediastinal lymphadenopathy, it has to be lymphadenopathy that is not complicated, not causing obstruction, and it has to be a lobar type of, not multi-lobar, but just one lobe of the lung. So it has to meet certain criteria to make sure that this is a non-severe tuberculosis case. But it's great because instead of having our patients be treated for 6 months, then we have now an option of 4 months if the burden of disease qualifies into non-severe TB at the beginning. And then the final two recommendations are related to drug-resistant tuberculosis. Thankfully, we don't have many of these cases in the United States, but we have cases here in Ohio as well. So there are new all-oral regimens for multi-drug resistant TB, as well as rifampin-resistant tuberculosis, which shortened, if you remember, some of you who have been on the tuberculosis field for years, you may remember that in the past, we had to treat multi-drug resistant tuberculosis with regimens that were 15 months, 18 months, up to 24 months duration. So we had patients who stayed with us for 1.5 years or 2 years, and some of those regimens required an injectable. So they had to get an injectable at least 5 days a week or a few days a week. So this is an amazing improvement, We're going from all those old days where there were injectables and many months of treatment, up to 2 years, to now 6 months of treatment. And the regimen, some of you may have experience with this, is a combination of bedaquiline, pretomanid, and linezolid, or also known as BPAL. If the isolate that is causing the disease is susceptible to quinolones, then you should be using or try to use moxifloxacin. So that's the M here, BPAL-moxi, moxifloxacin. But the core, as you can see, is these newer drugs, bedaquiline, pretomanid, and linezolid. Okay, so these two regimens, either BPAL or BPAL moxifloxacin, can be used for drug-resistant TB or rifampin-resistant TB. Include the moxifloxacin if the isolate is fluoroquinolone susceptible. And these recommendations are, the official recommendation is for people aged 14 years or older, just because the original trials included this population, the TB Practical and the NICS trial. There is an older trial that was the proof of concept trial, the XENIX trial, or the NICS trial, and then the XENIX trial that allowed us to look at the doses, because that's the other thing. Some of these drugs may not be tolerated that well. In linezolid, for example, we use a lower dose than the conventional dose for these kinds of cases. And these regimens are also treatment options for people with an intolerance to rifamycins. So if for whatever reason we have a patient who did not tolerate any of the rifamycins, we couldn't include rifampin or rifabutin or rifapentin, so then we will have to think about a bedaquiline-based regimen such as BPAL or BPAL moxifloxacin. So that's the summary of the recommendations. I think I am right on time. So I will stop there, and I will be happy to get us into the Q&A session, and hopefully there is some discussion. And thank you again for staying this late with us.
Thank you, Dr. Wahman. Yes, I can mind the chat. If anyone has any questions, go ahead and pop it in the chat, or you can raise your hand, come off mic. It's very informal. There's only about 33 of you, so you won't harm anything if you just speak on out. And if there are none, you have time to definitely think about it. I'm going to put out a QR code where if you think of a good question, you can pop it into the evaluation. I'll make sure it gets responded with.
I do have a question or a comment for Alex. Another aspect that, and I know that our team does that very well, is, and this is more difficult for to implement in contact investigations, is trying to identify also those high priority contacts who may not be high priority because of proximity or exposure, but because of immunosuppression, for example. So if we have someone in a classroom, since you were talking about a school investigation examples, if we have someone who we know is severely immunosuppressed for whatever reason, I think in that case we'll make a decision of testing, even though they may not quite meet the criteria for the first year of exposure, but that comes more from a host or from an individual perspective. And of course, that's difficult to operationalize because then that requires some knowledge of the medical history of the potential contacts, right? So, but I wanted to make sure that that was also brought up. Yeah.
And I appreciate that. And that really speaks to why it's essential to have a knowledgeable contact within the facility that you're investigating, especially if possible. There in large workplaces, there might be an employee health section. In schools, they're going to have school nurses. So having people like that you can reach out to specifically ask those questions of, you don't have to be very specific about it, but who in this group would you consider to be severely immunocompromised or otherwise meeting these criteria for high risk that we may not have considered? That's always very important to reach out for that additional information.
Thanks, Alex and Dr. Wallman. There's a question in the chat. So non-severe TB is not LTBI, correct? Criteria for non-severe.
No, it's actually different. That's a great question. Thanks for bringing that up. The recommendations that I have highlighted are all for active tuberculosis. They are not for latent tuberculosis infection. Latent tuberculosis infection is very different. There is a different set of guidelines for that. This is non-severe active tuberculosis. Yeah.
Thank you. Dr. Wallman, are there any research studies looking at the shorter course of treatment or less pill burden?
Yes, definitely. Unfortunately, that's one of the potential limitations with the newer regimen. We have had a couple of patients on this newer 4-month regimen at Hamilton County so far, and just rifampicin will be 8 pills, right? And then you have to add INH, which is 1. Then pyrazinamide is usually weight-based, maybe 2 or 3. And then moxifloxacin is 1 more, and then there is B6, right? So it's a significant number of pills. So hopefully in the future there will be better options with lesser pill burden as well. And that's something that is being looked at. There are other research studies as well that are looking at long-acting injectables, similar to what is happening in the HIV field, where instead of people taking pills every day, we may have an option to give a long-acting injectable that will be enough for weeks or months. And that is being looked at not only for active tuberculosis treatment, but also for latent tuberculosis infection treatment.
How likely is it for someone with LTBI getting treatment to convert to active TB? Can you explain the pathophysiology of that conversion?
Oh, that's a great question. Yeah. Traditionally, we say 5 to 10% of people with latent tuberculosis infection will progress to active tuberculosis. Now, that is in general, right? Now, if you have someone who has an immunosuppressive condition, I will put an example, HIV. So we know that HIV, people living with HIV will have a higher rate of progression to active tuberculosis. It's estimated that it can be as high as 10% per year. So much higher. In terms of the pathophysiology, that's a little bit more complicated, but the current line of thought is that that's why we're trying to get rid of the term latent, because apparently it's not really a latent, it's not really a dormant infection. We use those terms, and I use them all the time to try to explain to my patients, but it's not really fully dormant. So the studies show that there is off and on ongoing replication, maybe in the granulomas, in the lymph nodes. And if within that battle between the bacterial load and the host or the individual immune responses, unfortunately, the bacterial loads start winning that battle, then that's when you have active tuberculosis. And now we understand that there is a whole spectrum. It's not only latent and active. There is now a condition that is called subclinical tuberculosis, where patients may present just with abnormal chest x-rays. They don't have symptoms yet, but you may be able to isolate the bacteria if you do sputum testing, for example. So thanks for that question, and maybe some other time we can talk more about the pathophysiology, but it's not truly dormant. There is some residual infection in there that can lead to that active tuberculosis. Yeah. And that's why we do the prevention treatment, right? Sorry about that. That's why we do the latent tuberculosis infection treatment. The idea is to try to clear that bacterial burden. Yeah, that persistent bacteria that could then progress to active tuberculosis.
Taylor asks, is there information about number of successful treatments? Yes, Taylor, it'll be coming to you in a red cap survey by me this week. Once my brain is out of the spinner of how we're counting it. So this is something that we're kind of building here at Hamilton County, is to take note of how many patients have not only started treatment for latent tuberculosis, but finished treatment. We also track this for active TB. We do that more so because we have to report it, obviously, by the Ohio Department of Reporting Systems, or the Ohio Disease Reporting System. So active TB cases are much easier to keep track of their completion of their RIPE therapy over the 6 to 9 months of therapy, or maybe 4 or maybe 2, depending on how this year is rolling. Versus LTBI is not reportable. So that is something that a health department could implement into their clinic as they're monitoring. Like for our clinic, for instance, we do offer LTBI medication to patients who are positive QFT in a normal chest x-ray and not exuding any symptoms. So that is something that we are currently working on in our target testing and LTBI reporting that is distributed to a red cap survey by ODH and CDC yearly. And I think this is the second year. So the data is a little skewed. We're up against 2 different electronic medical systems. So and I hand counted. So I'm going to cry after this tuberculosis summit because I just hand counted 2 years worth of patients, but I'm fine. But in going forward, having this and keeping track of this quarterly is ideal for our patient, for our clinic rather. Dr. Woman, Summer asks a very good question. How do you decide if a patient should go with a RIPE regimen compared to a newer regimen that is 4 months?
Yeah, that's a great question. And I think there are several caveats there. We're asking ourselves those questions at the Hamilton County Health Department and try to figure out how to. At the end, I think it's also a shared decision with the patient, as much as they can understand. If they understand that there are these 2 regimens, and if we have the capacity to do both of them, then see in terms of pill burden and other factors, see what will work best for a specific patient. Like there may be some patients where giving them a treatment that contains a fluoroquinolone, such as moxifloxacin, for that long may not be a great idea, but some others where that's less of a risk. And there, I don't know, sorry for putting Dr. Hagland on the spot, but if Dr. Hagland is able to share her comments and her experience, that would be great. Yeah.
Well, so I so far have only tried starting the one gentleman on the new 4-month regimen. And I understand after speaking to you this week that he's having some trouble with that regimen. I'm looking forward. So we've got in Butler County, we also have seen more cases looking at the epidemiology. We had 14 in 2024, and we already have 6, I think, in 2025. And 4 of those are children. So I'm looking forward to counting, looking at those x-rays and counting lobes and seeing if some of those children can be treated for 4 months. That will, of course, be Mary Stat, the pediatric ID doctor's decision. But no, I'm very excited about having the option for, younger people that don't have other medical conditions who we could put them on the moxifloxacin without risking peripheral neuropathy or, sort of, we wouldn't have to be monitoring their EKGs for their QTs and all of that. I'm looking forward to finding people that would fit that category, but then that doesn't change the fact there's still going to be patients that have multiple cavities that need to be treated for longer. And I think, we shouldn't forget in our enthusiasm for the shorter regimens, for the less sick candidates, we still need to make sure that when we diagnose someone with TB that has multiple cavities and a heavy organism burden, that we need to get the levels of the meds, especially rifampin, right as soon as possible. And that would mean potentially, starting them on 900 milligrams instead of 600 milligrams of rifampin, and making sure that we're not underdosing the pyrazinamide because those have the early bactericidal activity. And so if we want to interrupt, if we want to shorten isolation, which we didn't talk about today, and interrupt transmission, we got to make sure that we got the levels in the person's lungs where they need to be as soon as possible.
Yeah, I agree, Dr. Hackland, and I think these newer regimens are not necessarily going to replace our traditional RIPE and all the experience that we have, especially with those cases where we may have to extend treatment. So, but it's good to have these shorter options out there. There may be some patients who will benefit from them. Thank you for the question. That was a very good question. I think we may be a little bit behind on time, and I see that there are more questions popping up. So we'll get back with you, Kate.
No problem. A couple of them are kind of quicker ones. I could probably knock a couple of these out. For Sarah, do you know why we do not enter suspected TB cases into odors until we start a 4-drug therapy? I from what I've been told from ODH is that you can input them if you'd like to, if you have the bandwidth. You don't have to wait. If you feel suspecting that this person's sputum might come back as positive, they're having symptoms, if they're starting empiric treatment, whatever have you. I do know that we at least send our sputum most everyone does in Ohio, sends your sputum to Columbus for testing. And usually they'll make them a chart anyway, or make them a case file anyway into odors to have their smear and culture result there. So it's kind of if you have the bandwidth, or more so if you have suspecting that patient's likely to be positive and you want to go ahead and start the reporting process. If anything, you can say not a case at the end of it if it comes back as Gordone or avium or whatever have you. Brittany, there will be, hopefully I record this correctly and I didn't do it last time the right way, but this way I have it down, I practiced. So I will be hitting the finish recording at the end of this, and I should be able to get the video to be able to send. If not, I'm happy to send the slide presentations of Alex and Dr. Wallman. James, 340B program. Does it cover drugs like rifapentine? I think you'd have to ask your 340B rep if that is covered in that program. I'm not very savvy with 340B just yet. We're kind of working on that with Avita. But Eva or Jackie Lindner might be on. If they have a better idea, I can let them unmute themselves. If not, I will take this question and get back with you. But I think right now the best idea would just be ask the rep. Hopefully that covered everything. Great. Eva says, yes, it's covered under 340B. Thanks, Eva. All right, well, I so appreciate everyone coming in. Let me go ahead and share my screen real quick and allow you all to see this in a presentation mode. Hopefully I did it correctly here. So just before you leave, go ahead and give this a scan in order to see if you can receive credits. The bottom credit designation should have for pharmaceutical, physician, attendance with no credit, if that's what you're looking for, ANCC contact hours, and for nurses, and I think I have IPCE. So I kind of did the whole gamut and social work. So go ahead and give it a scan. Hopefully it gives you at least the continuing education credits that revolve with your background and why you're here today. I can send this out in an email as well. This will only apply to individuals who are here for today's viewing. I can share the video, but it will not be open for contact sorry, we talked about contact investigation. Now it's just coming on out. Continuing education credits for later. In addition, I do have this end of summit evaluation. If you are currently working on that other piece that I asked you to scan, don't worry, I'll send this out.
Kate, it looks like the screen isn't being shared.
Which one?
There's nothing up on our screens, so we're not seeing anything.
Oh no. What do you see? Nothing?
The three of us.
Oh, fantastic.
We see you, Kate.
Is this better?
Yes. Yeah.
Y'all, it's late. I'm so sorry. Go ahead and scan that. She's doing her best. Okay. So yeah, so I will, now that I've cut out about 2.5 minutes of just me talking to the void, I will go ahead and just send this out to everybody for this QR code as well as the evaluation. We always appreciate feedback so we can better our summits in the future. Thank you again to Dr. Wallman and Alex for your fantastic presentations. Thanks everyone for coming out so late and for having such great questions for us. I hope you all enjoy your night. That concludes our TB Summit for World TB Month of March. Thank you.